So welcome. Welcome to the September ERA Journal Club. We hope you've had a great summer and you're not suffering from the rain that we're experiencing in the UK at the moment. This is the first ERA Journal Club after the summer break. It will happen every last Thursday of the month at 1700 Central European Time. That's 1600 here in Oxford. We're going to pick out a key topic, research article, probably an original research or a review article from either NDT or CKJ, and the authors will introduce their work. We'll have at least one expert on the panel, and the Journal Club is moderated alternate months by different groups of people, but this week it is Parminder Judge and myself, Will Herrington. We're Oxford-based nephrologists, trialists and epidemiologists. The discussion will be somewhat focused, but informal, live, and we hope it will inspire questions from yourselves. Please enter them in the Q&A box, and we'll try and address as many as possible. It's recorded and made available on various video platforms, so keep an eye on social media. So today's topic is intradialytic hypotension and how it might be managed in our dialysis units. It's a trial of low dialysate sodium, looking at 48-hour ambulatory blood pressure in patients, and it's a randomized trial with an interesting crossover design. That's quite an efficient way to study patients in a highly powerful way. So we're going to hear about the effects of low sodium, 137 milliequivalents versus a standard, and it's been published in May this year in NDT. And we're delighted that Fotini Iatridi, who is a nephrology resident and research fellow at Aristotle University in Thessalonica in Greece, has joined to present the findings. It was a collaborative venture and was led with her and Panellist Sarafidis, Professor Panellist Sarafidis, who's the senior author. So thank you so much for joining from Greece.
Thank you very much.
And we have Jule Pinter, who is a German-based nephrologist and trialist who we'll hear about later, is involved in more endeavors about dialysis sodium and randomized trials. So we've got a stimulating topic. It's really interesting. We've also got data that's being generated, which is an even larger test of the question. And I'm really excited about presentations today. So Fotini, over to you. But perhaps before you start your presentation, you could tell us what caught your attention about dialysate sodium, what's made you interested in it?
Thank you very much for the presentation, and this is a very good question. I actually think it is very interesting that the CKD population, in the CKD population, hypertension is so highly salt sensitive, and sodium fluctuations has so much effect on the blood pressure levels in these patients, and especially in patients in hemodialysis. So this was the main reason we focused on dialysate sodium concentration. I will begin with some introduction. According to the definition of the latest KDIGO controversy conference, any rise in systolic blood pressure over 10 millimeters of mercury from pre to post dialysis in at least 4 out of 6 consecutive dialysis sessions is defining now intradialytic hypertension. Early data regarding the prevalence of intradialytic hypertension came from a secondary analysis of the DMMS Wave 2 study by Inric and her colleagues, and showed that approximately 12.2% of patients in dialysis exhibit this increase in systolic blood pressure from pre to post dialysis. And among the earliest studies that brought to attention the poor prognosis of patients with intradialytic hypertension, here is the results of a CLIMB study, which assessed the relationship between blood pressure changes during hemodialysis and the composite outcome of a non-access related hospitalization and mortality. So as we can see, patients with an SBP rise during dialysis had at least twice the risk for the composite endpoint of hospitalization and mortality, and this was in adjusted analysis after adjustment for several cardiovascular risk factors. And this is data from probably the largest cohort study that evaluated the association between changes in blood pressure during dialysis and mortality. As you can see, it included an enormous number of patients, over 110,000 hemodialysis patients, with median follow-up of over 2 years. And as we see in the figure, large drops in systolic blood pressure over 30 millimeters of mercury, but also any rise in systolic blood pressure, you see here change over 0, were both associated with increased mortality, and we had this U-shaped pattern of association between intradialytic blood pressure change and all-cause mortality. So this association rose the question whether intradialytic blood pressure rise per se is the one associated with increased cardiovascular risk, or and if this is independent from the interdialytic blood pressure. And we have previously conducted this case control study in our center with 41 patients with intradialytic hypertension and 82 controls. And we observed that patients with intradialytic hypertension had significantly higher ambulatory blood pressure levels during the complete 48-hour interval. As you can see, with the black is the patients with intradialytic hypertension, and the gray is the controls. So based on this, we attempted recently to see the interaction between interdialytic blood pressure with mortality in these individuals, and we had a prospective study in which we examined the relationship of intradialytic hypertension with adverse cardiovascular events, and so that it was influenced by the 44-hour ambulatory blood pressure, with the associations were attenuated and lost significance. So there is definitely an interplay between interdialytic blood pressure and cardiovascular risk in this population. At least some percentage of the risk may be explained by the higher levels of interdialytic blood pressure. Regarding the pathophysiology, we know it is complex and definitely multifactorial. We have several factors contributed, as you can see in the figure. And of course, volume overload is a consistent finding among intradialytic hypertension patients, and is considered one of the most important contributors. This was a cross-sectional study of 531 patients who were assessed with bioimpedance analysis, and the authors found that those with increased post-dialysis blood pressure exhibited greater hydration levels compared to patients with stable or decreased post-dialysis blood pressure. And if we looked from the other way, the patients who had the highest extracellular water to total body water ratio were the ones who had the highest post-dialysis systolic blood pressure levels. And of course, we know that the positive sodium gradient suggests another important mechanism in the pathogenesis of intradialytic hypertension. Some preliminary evidence have showed that high sodium concentration may blunt the release of nitric oxide from the endothelium and cause vasoconstriction. And also, this was a very nice study that showed that intradialytic systolic blood pressure change is strongly associated with a dialysis sodium gradient. You see there is a positive linear relationship, which means that the higher the sodium gradient, the higher the intradialytic blood pressure rise, and also the higher the interdialytic weight gain. So this was the main previous study in this field of low dialysate sodium in intradialytic hypertension patients. It was another crossover study with 16 patients that showed that 1 week average intradialytic systolic blood pressure was reduced by almost 10 millimeters of mercury with low compared to high dialysate sodium concentration. And this comparison was between 5 milliequivalent per liter below serum sodium versus 5 milliequivalent per liter above serum sodium. And another recent non-randomized study with 50 patients also examined intradialytic blood pressure and compared low dialysate sodium of 136 versus the standard of 140. And low dialysate sodium again resulted in significantly lower post-dialysis blood pressure and fewer hypertensive episodes that required an intervention. So based on this background, our aim was to examine the effect of low compared to standard dialysate sodium, 137 compared to 140 milliequivalent per liter on ambulatory blood pressure during a complete 48-hour period for the first time in patients, of course, with intradialytic hypertension. This was a multi-center randomized single-blind study that had a crossover design. And patients were recruited from 4 hemodialysis units. We had a total of 30 patients, 3 units located in Greece and 1 in Slovenia. All patients received both dialysate sodium concentrations, 137 and 140, but they were randomly assigned to 2 groups which received the intervention in the opposite order. And block randomization stratified by gender was used to define the treatment order based on a computer-generated list. Here we can see the inclusion and exclusion criteria. Practically, we included adult patients with intradialytic hypertension based on the latest definition I already showed you, that were on hemodialysis for at least 3 months and who were at dry weight based on clinical criteria. And we excluded patients if a previous arteriovenous fistula could interfere with the ABPM, if they had serum sodium below 130 or over 142 at recruitment, if they were prone to hypotension or had a history of disequilibrium, recent modification of dry weight or antihypertensive treatment or recent hospitalization. How did we include patients? We assessed patients for eligibility based on records of peridialytic blood pressure measurements of a 2-week period, because we wanted to confirm the presence of intradialytic hypertension in at least 4 out of 6 consecutive sessions. We had a baseline evaluation performed before a midweek dialysis session, and in this we had physical examination, laboratory testing, we performed lung ultrasound to assess hydration, and we also performed blood pressure measurement with mobilograph device before, during, and after the dialysis session. After this, the 2 groups received different dialysis sodium concentrations. We had the first group who received 4 sessions with low and the other group 4 sessions with standard dialysis sodium, again starting from a midweek dialysis session. It was Wednesday or Thursday. A 2-week washout period with standard dialysis sodium followed for both groups after, as you can see it here on the figure. And then the participants underwent another set of 4 hemodialysis sessions with the opposite dialysis sodium concentration. And before the start of the 4th dialysis session, during each of these periods, patients were assessed with lung ultrasound again and 48-hour ABPM. The ABPM was performed with a mobilograph NG device, as you can see in the figure, and we measured blood pressure every 20 minutes during daytime and 30 minutes during nighttime, as most studies using ABPM. In case we had an invalid recording, patients were repeated the ABPM 1 week later, remaining on the same dialysate sodium concentration. And now we move on to the results. Here is the flowchart of our participants. So from a total of 187 patients that we assessed, 30 participants fulfilled the inclusion and exclusion criteria. And of course, most of the participants excluded because of not fulfilling the definition of intradialytic hypertension with 4 out of 6 consecutive sessions. It's very important to have the reproducibility of this phenomenon. Among those participants, 14 were randomized to group A, and 16 to group B, and 9 of them had to repeat 1 measurement because of an invalid recording. Among them, 1 patient refused to have again the ABPM, and he withdrew consent, and so we had a total of 29 patients who completed the study and were included in our analysis. Here are the baseline characteristics of the population. Our participants had a mean age of 64.6 years and median hemodialysis vintage of 28.7 months. As you can see, they were all hypertensive, and around 40% of them had diabetes mellitus, which was the most common cause of end-stage kidney disease, and 40% of them approximately had coronary heart disease. The most commonly used antihypertensive medication were CCBs and beta blockers, and we had baseline measurements of pre-dialysis blood pressure. As you can see, it was 148.8, and post-dialysis total blood pressure were 167.3, so had a big intradialytic systolic blood pressure rise. And here are the results for the 48-hour ambulatory blood pressure. We have the mean 48-hour systolic blood pressure, which was significantly lower with the low compared with the standard dialysis sodium, 137.6 versus 142.9. And similar results we have for the diastolic blood pressure. And here you can see the trajectories of the systolic and diastolic blood pressure with the low and standard dialysis sodium during the complete 48-hour period. These are the data for the patient in the morning shift, and we have marked the dialysis session from 7 a.m. till 11 a.m. And you can see the significantly lower blood pressure levels with a lower dialysis sodium with the gray line compared to the standard dialysis sodium, which is the black line. We also had important results regarding post-dialysis and intradialytic blood pressure. Both showed significant differences between the two dialysis sodium concentrations, and you can see again lower blood pressure levels with low compared to the standard dialysis sodium concentration. And this figure shows the changes from baseline in peridialytic systolic blood pressure. The intradialytic systolic blood pressure reduction was significantly greater with the low dialysis sodium. We had a drop of minus 6.1, while, as you can see, there was no change with standard dialysis sodium concentration. And same and even more pronounced difference for post-dialysis systolic blood pressure. We had a reduction of minus 16.8 with low dialysis sodium, and again, practically no difference with standard dialysis sodium. And here are the results for the volume-related parameters. We have here interdialytic weight gain, which was again lower with the low dialysis sodium concentration, and a similar result for the pre-dialysis weight, which was again lower. And here are the USB lines, which were assessed with the lung ultrasound, and we see, although we have big confidence intervals, we can see that they were slightly lower with a low dialysis sodium concentration. And this is the results for the different time intervals. We can see again ambulatory systolic and diastolic blood pressure during 48-hour interval first and second daytime, second 24-hour daytime interval were significantly lower with a low dialysis sodium, while nighttime blood pressure during the same period was only numerically but not statistically lower with the low dialysis sodium. And finally, here we examined some potential associations of blood pressure differences with parameters of interest. And as you can see in the figures, the difference between the two concentrations in 48-hour systolic blood pressure and post-dialysis systolic blood pressure had an inverse correlation with the average intradialytic systolic blood pressure rise over the 2 weeks of the selection period before the study initiation. So this means that the higher the intradialytic SBP rise, the more negative was the difference between the low and high dialysis sodium. So we had larger drops with the low dialysis sodium. Regarding the rest of the parameters, you can see no correlation we had with baseline serum sodium, sodium gradient, and USB lines, though it was a small study population. So now to the conclusions, we saw that mean 48-hour systolic and diastolic blood pressure were significantly lower with the low compared to the standard dialysis sodium in patients with intradialytic hypertension, and the same pattern of lower blood pressure with lower dialysis sodium was also evident across the different 24-hour daytime and nighttime intervals. Low dialysate sodium had significant reductions in post-dialysis and intradialytic blood pressure, and also the volume-related parameters, the pre-dialysis weight, intradialytic weight gain, and USB lines were also significantly lower with a low dialysate sodium concentration. So we can conclude that our findings certainly support the use of low dialysate sodium as an important non-pharmacological approach for the blood pressure management in this specific population of patients with intradialytic hypertension. And this is our NDT publication. And thank you everyone for your attention.
Thank you. That was really nice. I really enjoyed listening to that. I think first reactions is that it's a very precise question in a very precise population, answered with a very simple outcome in a short-term study, which measures a marker of risk that we're fascinated about as nephrologists. And the results look really clear to me. Were they what you were expecting from the observational data from other work? Was this the size of effect you were expecting? I think it's a large effect on blood pressure. Were you expecting 3 milliequivalents of liter difference in dialysis over, was it 4 sessions, to have such a marked effect on both dry weight and on blood pressure?
Yes, we had previous studies that showed some data, but only data regarding the intradialytic blood pressure and post-dialysis blood pressure. So we expected somewhat around 5 millimeters of mercury for the intradialytic blood pressure. This was a little higher, but we did not know what to expect for the ambulatory blood pressure. It was just, we had no data regarding this measure.
So remind me, I didn't catch it. How much did you when you powered the study? What was the number you were aiming for? Was it 5?
Yes, we had in the statistical calculation we aimed about 5 millimeters of mercury in the blood pressure between the groups of low and standard dialysis.
Yeah. And did you observe any patients not requiring as many blood pressure treatments, or were they required to be fixed throughout the study so that those changes?
We tried to have it fixed in order to not have the confound effect of lowering the medication and the interpretation in the blood pressure levels. It was a fix. Also, dry weight was it was not allowed to change during
change dry weight. Yeah. So this was the natural what we observed.
So the lower dry weight was in line with a lower interdialytic weight gain. So if they didn't gain weight, they had lower pre-dialysis weight.
And one more question before I turn to Jule, because is what do you think drove that difference in intradialytic weight gain? Is it simply because you have dialyzed out more sodium and so there may be less thirst between? Is that your hypothesis?
Yes, I think the lower interdialytic weight gain and also the slightly lower USB lines in the lung ultrasound we performed guided us to this direction. We believe it was a volume-related mechanism that drove the blood pressure reduction, mainly, at least.
Jule knows these data further around this much better than I, because she's so involved in this type of thing. So Jule, what were your reactions when you saw these data?
I was very positively surprised. So first of all, it's a really great study. It's very dedicated in a subset of patients. And I assume that you, as you probably did not have any industry funding, you did have to put a lot of effort into it to make it realize. So how long did you actually need to recruit these type of subset of patients?
Yes, you're absolutely right. We didn't have so much people to be on this, so we needed a long time to gather. It was approximately 1 year to find the 30 patients because it's only a small subgroup of the dialysis population, so we had to include other dialysis units in order to find patients that were willing to participate and complete the study. So we had around 1 year.
And that's what surprised me in a very, positive way, because obviously the gold standard is 48-hour ambulatory blood pressure. And I think this is the first study. So it goes in line with the other very small studies that we have that were also dedicated to other small target population, but it does show that it has quite a large effect. So how long in total was the intervention time the patients received? How many weeks did they receive a change in their dialysate?
Yes, we opted for a rather small and number of sessions. We had only 4 dialysis sessions for its intervention, because we wanted to keep the total duration of our study rather short, in order to avoid patient dropout, because we had already a small population. It was 4 dialysis sessions with its concentration.
So probably together with the washout, which I think was also a very efficient way to save sample size, is probably around 5 weeks.
Yes, it was 5 weeks.
Yes.
Baseline to end of
and this is astounding, because I think the majority of patients with the 2 weeks of washout included received 140 for a longer period of time. And so when they did have it does actually show that there is quite an effect, and it doesn't take long to come into action. So it's something that is happening during the sessions. And I was wondering, what would you postulate if you had the means to run another study that would probably go for 16 weeks if you found the right type of patients again? Would you think that it's sustainable, that this effect would not, that it would be persistent?
Oh yeah, this is this would be it would be great if we could do it for longer periods to see if this is a sustainable effect. I believe that we could see a sustainable effect if we included broader population, larger population than 30 patients, because we would have to think about all the confounding factors that would maybe have an effect on blood pressure. If we had the 3 months or maybe longer intervention, we could not have a steady antihypertensive medication, or a steady dry weight, or a steady diet, because maybe the change in consumption of salt maybe also interfere with our results.
You just mentioned that you controlled the management in both arms. How did you do that in the 2 units? I think there was one in Slovenia and one in Greece, right?
Actually, we have 3 units in Greece and 1 in Slovenia. The 2 units that were in Thessaloniki, where most patients were recruited from these 2 units. I was in charge of them, so I couldn't be in multiple positions at the same time. So this took a little longer. And we also had colleagues in Athens and in Maribor of Slovenia who ran the procedures there.
Okay, so if you were to do this trial again, I think you suggested you could do a longer trial, which would be interesting. What would be the other things you would check? Now you know that this looks like in people with higher or blood pressure increases during dialysis, that this low sodium proceeding lowers blood pressure. What would you do next in terms of studying different populations? Could this be studied in a wider range? Why don't we study the people with no change in blood pressure during dialysis, or even those that have fallen blood pressure? And if we did, what would you measure? I mean, there's more than just blood pressure. And what would you measure in terms of trying to understand the mechanisms better and the effects on physiology?
Yeah, so if we had to do it again, there were some things that I think that could be improved. One thing that is that we could have a more, we could assess volume as an inclusion criteria. I mean, we wanted to include patients that are in everyday dialysis units, But if we wanted to see if the underlying mechanism is actually volume related or if there would be no effect if patients were absolutely in a great volume balance, I think we could assess with ways like bioimpedance analysis or lung ultrasound and include only patients that would be in dry weight based on this criterion. But also, I think this population had an important effect, but I think the broader population of the dialysis population should be studied in larger trials to assess the hard outcomes from dialysis, from lowering dialysis sodium concentration, because we could not see hard outcomes in this. We had intermediate outcomes like blood pressure in this study, but I think harder outcomes with lower dialysis sodium should give us a lot of answers for the general dialysis population.
I mean, I find this fascinating. I'd like to know, we've always been told by the dialysis community that fatigue is one of the key symptoms. So I'm interested in what you postulate might do to fatigue, and maybe that should be measured in future trials. I think what this really does show is that there's small changes in how you dialyze people could have quite marked effects on physiology. I'm wondering what the harm would be to implement now in everyone, using 137 instead of 140. Is there a safety risk that lowering sodium might generate, or is this something simple that everyone could do to try and modify people's blood pressure on dialysis?
I think we were relatively safe because this population has by definition an intradialytic blood pressure rise. So we did not expect any adverse symptoms during dialysis, and also we had a very, if I may say, conservative threshold of 137. It's not very low to be afraid of intradialytic symptoms. But maybe for the general dialysis population, the things would be different. Maybe patients of older age maybe respond differently and have maybe frail patients that are prone to hypotension. Maybe they could not have the same results regarding safety.
So I think this is an interesting question. It's quite motivating to want to do a large outcome trial. And I think that Jule might be able to tell us a bit about what might be coming up in the future. Jule, did you want to tell us a bit about what you're working on?
Yes, wonderful. I can also share my slides. Can you all see them? Yes, so there are basically no relevant disclosures to report, just non-profit association with Fresenius Medical Care. Yes, so there is a large outcome trial or study running at the moment. It's called Randomized Evaluation of Sodium Dialysate Levels on Vascular Events. And it's very complementary to the small mechanistic studies. And the question it addresses is slightly different in that it does look at the long-term effect of dialysate sodium, and it does look into the effect of what a standardized concentration could look like if you apply it to all patients in a unit. And basically, what happened in the 2010s were that the Dobbs analysis came out and people found out that there's not a lot of variance in dialysate sodium prescribing practices, that most nephrologists tend to use a standard concentration. And so that now we do have this small study, but it's incredibly hard to recruit dialysis patients. So it took 1 year to recruit 30 patients, and that a large outcome trial was required. And so Resolve was really designed to mimic that, what is done in practice, in trying to evaluate this question. And I think these results very well show that in a subset of patients who are hypertensive, it does have a strong effect. Some of them still had some degree of residual renal function. But what happens in these other patients who are maybe frail, older, anuric, who are prone to hypertension? Might they benefit from a higher dialysate sodium? And so mimicking that, what nephrologists actually do in practice, the study is designed to look at a standard concentration of either 137 or 140, similar to what you did in Greece, to look at a hard clinical composite outcome of hospitalized myocardial infarction, stroke, and all-cause death for a 10% relative risk reduction. So this is quite interesting, the data we just looked at, because if it's 5 millimercuries of mercury, then the effect might be even larger. We don't know yet. It's an investigator-blinded study, which is well underway. And it does mimic what nephrologists do. So it's for the whole general population. So most of the countries that are participating in Resolve do have an opt-out so that you can implement the standard for all the patients in the unit that are affected. And so also the older patients, the ones that might not participate in a typical trial, are then randomized within the unit standard. And Resolve has been going on for quite a while. It's run by Meg Jardine at the NHMSC trial unit at the University of Sydney. It's happening at almost all continents. And we're now well ahead. So if we just think about the big sample size here, it's 414 sites globally. And we're about at 300 sites now. Yes, and so we expect that recruitment will be closed in 2025 and that there might be some results we can report on in 2026 to definitely be able, in a hard outcome study, address that question. And then complementary to what you found, we might not only have a standard concentration and more confidence in what we can actually apply in all the dialysis patients, but also then have the mechanistic data to what we should do in subset of patients like the ones that are prone to hypertension.
It's a very exciting study, absolutely enormous. It's cluster design. I mean, the question that links these two studies together is, well, first of all, you've got an excellent hypothesis. It sounds like Resolve is testing at least one key mechanism which could drive reductions in cardiovascular risk. And obviously, we have very limited data in the dialysis population, which is extraordinary high risk of structural heart disease as well as atherosclerotic disease. I guess the difference between Resolve and the study from Greece and Slovenia is that there's a very specific population studied initially with a rise in blood pressure. So in Resolve, it's a cluster design, and I've got a very specific question for you, Jule, about whether you will be able to classify patients at baseline into their different types of blood pressure change during dialysis sessions before you actually, start the intervention. So are you going to be able to look at people and say, well, here was a riser, here was a faller, and here was a no changer, and be able to identify subgroups of patients? And then is a subgroup analysis possible with a cluster design, given that you're randomizing units at scale? So a hard question for you, Jule, but
so the primary design is very pragmatic, and it does work with routine data. And that means that one of the hardest thing in Resolve has been that it's such a classic and simple design, but all the different systems, healthcare systems, use different systems on how data are collected and have different ethical standards and how you can include people into studies. That has largely limited. So that's why Resolve is so simple. It says, put all the patients in, the prevalent patients in, then reflect the whole patient turnover. So every patient that is then, a new patient after the unit has been randomized will receive the standard 2, will also be, counted in the follow-up events. And I'm strongly hoping that with secondary analysis, because we have, for example, the UK, which has a very good national registry, and other registries, we will be able to match those data also in terms of blood pressure, because currently we're not collecting blood pressure. We're collecting a minimum of data points to make it as feasible as possible across the different systems in the world. But because the sample size is so big, it's going to be, I think, over 50,000 patients with almost 27,000 events. Then in subset of patients in the UK, and we're still hoping in Germany, we will also get some mechanistic data yet to come to then be able to look at those patients. And I think this would be very important, because then we could extrapolate the findings and also, for example, look at what happens with patients that have heart failure, what happens with patients who are hypertensive, and then get more results also on the mechanistic effects.
Interesting. Any clues when we might hear the results? How long is it away?
Yes, I'm strongly hoping 2026.
Okay,
So,
very exciting. We don't have to wait too long. Fotini, Parminder, did you have any questions for Jule?
Not from me personally, but there were several from the audience, particularly around kind of, you know, what would you do about your patients who potentially have a much lower sodium at the outset? So, you know, 130, 135. Are you then having to raise the sodium ahead? You know, how are you sort of checking the sodiums in advance? And are you using sodium profiling to overcome intradialytic hypotension or hypertension as a sort of a standard treatment now following the results of your study? So some thoughts and questions from the audience there.
Do you think about resolve now, Parminder?
I think this is a more general question.
Yes.
Yeah, these are general questions.
Yeah, so I think the first question is for Tina. What are you doing now? Are you now 137 for everyone in your unit who's got a rising blood pressure, or are you randomizing to resolve?
I think regarding the patients with very low pre-dialysis serum sodium, the first to address would be if they are extremely volume overloaded, and if this is actually from dilution, the low pre-dialysis sodium, or maybe something else, like some patients have low pre-dialysis sodium because of bad nutrition status, or frail patients may have lower pre-dialysis sodium. I think either of the concentrations that we are discussing, especially the 137 in these patients, may not have so different effect than 140, because it's already higher than their serum sodium. So at least theoretically, they will have a positive sodium gradient, and they will have a sodium gain during dialysis, and probably won't have intradialytic symptoms like hypotension during dialysis. So I think the question is more about the patients with higher pre-dialysis serum sodium.
Okay, and what do you do now? Are all your patients with rising blood pressure at 137?
Actually, now we are we have decided to lower dialysate sodium in some patients that have persistently higher intradialytic blood pressure levels. I mean, we have gone to 137, but not all.
And are you doing any more studies? Are there any more analyses coming from this data? Are you collecting more data? Are you doing a trial of 135 versus 137 yet?
No, we have not started another trial with another concentration yet, but now there are a few data that are coming regarding the aortic blood pressure and the arterial stiffness parameters, because increased arterial stiffness is also a mechanism that could contribute to higher blood pressure or increased cardiovascular risk for these patients. And we would like to see if we have similar results in these indices as well.
Great. Okay, well, I look forward to that being published. I think we should call time on the seminar now. So thank you so much from the ERA Journal Club team to you both for joining and for sparing your time and for sharing all of your blood, sweat and tears, randomizing and following all these patients up. Congratulations on the publication. If the listeners want to come to the NET website, they can find your paper, but also last month, I think your group also published in CKJ on ambulatory blood pressure in hemodialysis patients and looking observationally at dialysate sodium. So there's more papers to look at if you want to read beyond this topic. For those of you that listen, thank you for staying. We appreciate it. Please do go and answer the survey at the end on Zoom. It helps us keep this journal club running. And that just leaves me to say thank you so much for joining, and please come back next month, the last Thursday, for our next e-seminar.